Hello, Jalesh. Thank you very much for that fantastic presentation. It was great. We were all really engaged in it. I just wanted to know from you, where do you feel that we could work together more collaboratively between your specialty and rehab medicine?
Well, Mary, I think there's quite a few areas that we can actually work together. Neurogenic bladder, I imagine, is sort of bread and butter of what a rehabilitation specialist does. And so I suppose there's ample opportunity to develop shared care pathways.
Yeah.
I suppose in the assessment of the patients, there would be at some point patients that require specialist input, hematuria, for example, stones, upper tract risk. And I think having a urology link is useful. Sometimes you might be presented with patients where actually the neurologists aren't very sure about the diagnosis. Scan negative cardiac I'm sure they come through to a neuro rehab unit, in which case having a Uro-Neurology input, the neurology input is quite helpful. And also, I suppose it's a pathway where you have sort of optimized management and you feel the patient requires further treatments. Botox, for example, or sacral neuromodulation, or perhaps urological surgery. And so I think there are different levels at which that sort of interaction can happen.
Yeah. And where you're working just now, what sort of services have you got there that potentially we could get involved in? Do you have a service already started with that?
Oh, yeah. So we have a very close collaboration with our rehabilitation unit. Physically, we're on the same building, which helps. We also have a consultant who works between Uro-Neurology and spasticity, which is an additional link. But we actually do run a ward round every month.
Okay.
And so one of us, the medics and one of the nurses, will come up, and there would be patients who are sort of identified in the rehab ward who have some special urological needs. And it's an opportunity to discuss, these patients. What used to happen before is that we would get a referral sort of midway through the admission, or perhaps towards the end. They require A, B, and C investigations. And it's difficult to sort of get them done through before the patient returns home or is repatriated. So with involvement from the first week onwards, we have time to build in these investigations, have them discussed at our MDT meeting, and then go back to the ward round and say, look, this is what we need to achieve, plus a bit of follow-up. So I think having that sort of a team meeting or building in some urology input into a team meeting goes a long way in trying to put together a care plan for the bladder management.
Yeah, that sounds absolutely really interesting. And have you seen some very good outcomes with that model that you started within your service?
Well, so I suppose what we're seeing is less outpatient referrals because these patients now have a clear care pathway. You do see patients who are going home continent. You have patients who are on the right type of catheters. And part of this work is we're trying to develop a care pathway for suprapubic catheter insertions. We're not quite there yet, but I think if that is developed, then potentially patients could get their SPCs in before they go home.
So there's definitely a lot of work that we could probably do together within your specialty and our specialty, which is really great.
Absolutely.